Hello, my dear future nursing officers. Welcome once again, everyone, to the master nursing classes. Here in this today's particular video, we are going to discuss those golden, high yield, very important content, questions, concept with a rapid revision manner for your upcoming RRB nursing superintendent exam and Norcet 8 mains exam. This is the content which is repeatedly striking in our exam, where the students are getting confusion and where the marks are lagging behind. So I want to boost your those backward point to bring up you in the selection list. So I will do myself best and best. So all you people have to work together me, and how much I am giving the I am doing the efforts. So more than me, you people have to do at least a 10% more than me. So then your selection becomes the sure. Okay. So here we'll start the today's class with a beautiful motivational quote. Bacho, when you will see surround of you people, there are many starters are there, beginners are there. They will start the process. But at the end, who will finish better, he will win. So always I keeps on telling you people, be a best finisher. So how you will finish the game, that will give the result whether you will win or whether you will lose. If you want to wait for the till prelims exam, you can wait. But I can't wait. I will start the class today. I will finish the class today. If you want, you can watch. Right? So I want my students to be completely focused on their exams without any distractions, and they have to give their 101 percentage. Yes, so then only a result will come in a good way. Then only the something will change in your life, right? So there are better starters are there than me, but I am the strongest finisher. This word you everyone should say. I am the strongest finisher. When you say this word, you will get a somewhat extra level of the confidence for your upcoming mains exams and upcoming RRB nursing superintendent exams. And many of you are sending a message, sir, please conduct the classes for the RRB nursing superintendent exams. Bacho, whatever the classes I have took previously, that is both for the Norcet 8 prelims, both for the RRB nursing superintendent exams. So there is no separate nursing subject syllabus for the RRB nursing superintendent exams. Yes, the same syllabus is there. Whatever the direct questions came in your prelims Norcet exam, the same direct questions will comes in your RRB nursing superintendent exam. Whoever didn't watch the video till now, so the playlist is there of the rapid revision videos where the golden content is filled in that one. So you can utilize that one without paying any single rupees. Okay. So with this, we'll start the today's a specific video for the mains and RRB exams. So here's the first question. All you people have to face and give the answer. That is the very important question. Okay. Consider this one as in the 1,000-star question. Okay. So this is a 1,000-star question. Which of the following is not considered as the common warning sign of the cancer? Which of the following is not considered as the common warning sign of the cancer? Option A is there. A lump or thickness in the breast or elsewhere. Option B is there. An unexplained weight loss due to indigestion. Option C is there. This is the indigestion. Okay, not separate. This is the indigestion together. Okay. Then comes the option C, a persistent cough or harshness of the voice. Okay. Then option D, the sudden improvement in appetite and energy. So among all these four options, which is not a warning sign of the cancer. So whenever the examiner throw a question on you people on the warning signs of the cancer, always remember a mnemonic, that is the caution. Okay, so this is very important, but definitely it will strike in your mains exam and RRB exam. Don't neglect this one. Let me rapidly revise the caution. C stands here as the change in the bowel and bladder habit. It indicates some GI system related cancer happened if the change in bowel and bladder movement is for the months together. Okay, then comes to the option A, sorry, second point, that is the A. So a sore that does not heal, somewhere in the body there is a development of the sore which is not healing, so that may indicates there is a chance of the cancer, and which is the warning sign of the cancer. Then comes to the U. U stands here as the unusual bleeding or the unusual discharges, especially from the genital area, where it may indicate the cervical cancer and uterine cancer. Then comes to the next point, there is the T. T stands here as a thickening or the lump in the breast or elsewhere. This is the warning sign of the breast cancer. And if you are finding lump elsewhere in the body, so that is the warning sign of the cancer. Okay, presence of the lump or the gant. Okay, what we can say in the Hindi, so we can say the gant. Okay, so this kind of the lump anywhere you are finding in your body means that may indicates the cancer. Okay, so then comes to the option. Sorry, next point, there is the I. I is the indigestion, means there is difficulty in digesting the thing and difficulty in swallowing the thing, so this may indicate the cancer of the GI system. Okay, then comes to the O is the obvious change in the wart and mole. Any warts are there on your skin or any mole are there on your skin, so this mole and wart which is changing, okay, which is growing, which is developing, so that is indicating the obvious change in wart and mole, also a warning sign of the cancer. Then comes to the N. N is the nagging cough or the harshness of the voice. Okay, so this harshness of the voice is a classically indicating the cancer of the larynx. Okay, so the classical picture of the laryngeal cancer is the harshness of the voice. Very, very important, bacho. So this is what we have to remember when someone asks us a warning sign of cancer. Okay, so it's a very, very important, bacho. So now here a lump and thickness in the breast, this is a warning sign of the breast cancer. Unexplained weight loss and indigestion, this is a warning sign of the GI cancer. And persistent cough and harshness, the warning sign of the laryngeal cancer. Sorry. A sudden improvement in the appetite and energy, this is not a sign of the cancer. So in the question also they have mentioned not. So our answer goes here as the option D. Very, very important. Don't forget the caution. Okay. So then comes to the next very, very important question. Which of the following is a tumor marker which is most commonly associated with the epithelial ovarian cancer? 1,000-point important question, bacho. Okay. 1,000-point important question. So here option A is telling the alpha fetoprotein. Alpha fetoprotein is in the tumor marker for the liver cancer. Okay, then CA125 is a tumor marker for the which disease, and carcinogenic embryonic antigen, then a prostate specific antigen. So you people have to choose the answer. I'm waiting for your answer here in the comment box. Okay, what is the tumor marker that is most commonly we have to use in the epithelial ovarian cancer? Very good evening, beta. Very, very good evening. So I'm waiting for your responses in the comment box. Yes, very nice of you all. Epithelial ovarian cancer, the classical tumor marker is the option B goes to the correct answer. Okay, the prostate specific antigen is the tumor marker for the prostate cancer. Okay, so here are the very, very important tumor types and its specific markers. So definitely one MCQ, it will comes in your upcoming mains exam and RRB nursing superintendent exam. Fix one MCQ. Fix. Okay, fix one MCQ. So the tumor markers are like here the ovarian cancer, cancer antigen 125, or we can say the CA 125. Then prostate cancer, prostate specific antigen, hepatocellular carcinoma or the liver cancer, we can say the alpha fetoprotein. Then testicular cancer, beta HCG and alpha fetoprotein. One you want to choose means choose the beta HCG. Okay, then comes to the choriocarcinoma. Okay, so the choriocarcinoma is the tumor of the gestational trophoblastic disease. Okay, here the tumor of the trophoblast cells in the uterus of the mother. Okay, the choriocarcinoma tumor marker is the beta HCG, and testicular cancer tumor marker is the beta HCG. Then comes to the colorectal cancer, that is the Very, very important. CEA. Okay. So then comes to the pancreatic cancer. Okay. So that is the pan. That is the 199. You can remember how you can remember that is the pan 199. N. Okay. So that is the pan 199. You can remember for the pancreatic cancer. Okay. So least it's not that much important, but remember this one. Okay. Then comes to the very, very important breast cancer. Most important and most important point. All you people have to remember breast cancer. That is the CA 15.3 and CA 27.29. Okay. So these are the very important. Then comes to the medullary thyroid tumor, the calcitonin. Important. Then comes to the multiple myeloma, Benz-Jones protein, the 1,000 point important question. Okay, so the examiner just throw the question where you will find the Benz-Jones protein or the M protein. Okay, so most important that is the multiple myeloma, BG protein or the Benz-Jones protein or the M protein. Then neuroendocrine tumors where you can see the chromogranin A may be the tumor marker. Okay, it's not that much specific. Still, only one is there, so we can use that one. Okay. Then comes to the pheochromocytoma, that is the vinyl mandelic acid or metanephrines are the tumor markers we can use here. Okay. Very, very importantly, they will ask the question on the vinyl mandelic acid. Okay. It is in the metabolic end product of the epinephrine, norepinephrine, where the medulla of the adrenaline gland is getting the tumor, where the chromocytes of the medullary gland are rapidly growing. Means yes, our chromocytes in the medullary gland are responsible for the formation of the epinephrine, norepinephrine. Okay, so where a pheochromocytoma is there, means the chromocytes will develop very rapidly. Then excessive epinephrine, norepinephrine will releases. So excessive epinephrine releasing means that metabolizes epinephrine, norepinephrine metabolism means that will get converts into the vinyl mandelic acid. Okay, VMA is the tumor marker for the pheochromocytoma and multiple myeloma, Benz-Jones protein, very, very important, and medullary thyroid tumor, very important, calcitonin. Then comes to the pancreatic, that is the pan 199. Then comes to the our choriocarcinoma, that is the beta HCG. Then hepatocellular carcinoma, alpha beta protein, testicular carcinoma, beta HCG, ovarian cancer, CA125, prostate cancer, prostate specific antigen. It's a very, very important. Bacho, take a screenshot of this one and revise immediately after the class. Okay, so here is the next question. Which of the following cells acts as the resident macrophage in the liver? Okay, so in the liver, which cell is a very important macrophage which is responsible for the defense mechanism, which is responsible for the protection of the liver? Okay, so which cell? Option A, Kupffer cell. Option B, Langerhans cell. Option C, microglial cell. And option D, osteoclast. Okay, so your answer goes here. Yes, I am waiting for your answer. Very easy question. Very easy question. And most important question for your upcoming exam. Okay, so for your RB nursing student and Norcet, it means very, very important question. Okay, so that is the comes to the answer here. The Kupffer cells are the cells, macrophagic cells, which is there in our liver. Okay, so the Langerhans cells is there in our epidermis, or we can say it is there in our skin. Then the microglial cells are the macrophagic cells in the brain, or we can say the central nervous system. Very, very important. Osteoclast are the cells, are the bone resorption cells in the bone. Very, very important. Okay, so then comes to the rapid revision of the points where the actual organs or tissue is there, and it's a specific macrophagic cells which is repeatedly asked in the exam. The liver is the, that is the Kupffer cell. Lungs is the alveolar macrophage, we can say, or we can say that is the type 3 alveolar macrophage. Very, very important. Then comes to the central nervous system or the brain, the microglial cell. Okay, this is the type of this glial cell which is act as a macrophage. Okay, there is the brain or CNS is the microglial cell. Then comes to the skin and epidermis. There is the Langerhans cell. The bone is the osteoclast. Then spleen and lymph node is the sinus histocytes. Very important. Then comes to the placenta, Hofbauer cells, and peritoneal cavity, peritoneal macrophages. Sir, I don't want to remember all. Just tell me the 3 things or the 4 things that you have to remember. Remember the liver, lung, CNS, then placenta. Okay, so rest of may ask, may not ask. Okay, that is very very important. So if you are remembering everything, that is very nice. Okay, because this is a very hard and high topic. So don't, no exclusion in the hot and high topics. Okay, there is no exclusion in the hot and high topics, right? So hope it is clear to everyone. Okay, so the next question will comes in front of you. Just wait a second. Okay, so hope it is clear. And the answer for the previous question is clear. There is the co-cells. Okay, then comes to the next a very very important cells, bachcho. Very important questions for you all. So I'm waiting for your response in the comment box. The question is very simple like this. Which of the following type of mastectomy removal of the entire breast along with the pectoral muscles and axillary lymph nodes? Okay, so what happened here? The mastectomy. The meaning of the mastectomy is the removal of the breast. Okay, it's a breast surgery. We are surgically removing the breast. So that is what we call as the mastectomy. In the mastectomy, there are very very important types of the mastectomy where the Norcet throwing the question every time and where the RB also asked the question 2 times. So it's very important to know and study about the mastectomy. Just I have told the meaning of the mastectomy is the yes, mast means that is the breast, ectomy means removal. Okay, the mastalgia is the pain in the breast. The mastitis is the infection and inflammation in the breast. Yes, let's revise once again. The mastalgia is the pain in the breast. Mastitis is the yes infection inflammation of the breast. Then mastectomy is the removal of the breast. Very very important. Okay, so here it's a type of the mastectomy where we are removing the entire breast and along with the pectoral muscles we are removing. So and axillary lymph node also we are removing. So in the option we are having the simple mastectomy, modified radical mastectomy and lumpectomy. So what is the correct answer? I'm waiting for your response. Yes, whether it may right or whether it may wrong. Try to give the answer. If you are right, so yes, you can say I am a best finisher. If you are wrong, you can say I am best corrected finisher. Okay, whatever the wrong you have made, you have corrected this one. Okay, you can say yes, I am best corrected finisher. Okay, so always best corrected finishers are more stronger than the best finishers. Remember this one. Okay, yes, whether it may right or wrong, so try to give your answer. Yes, the answer goes to option C here. That is the radical mastectomy is your answer. Bacho, in the MRM surgery, or we can say the modified radical mastectomy. In simple, we can say this one is in the MRM surgery. Okay, so here we are removing only a breast plus level 1 and 2. Okay, level 1 and level 2 lymph nodes. Okay, so the just breast and level 1, level 2 lymph nodes we are removing means that is the modified radical mastectomy. Let's quickly revise all type of the mastectomy and it's a very important special notes on that one. So it will be helpful to you people in the upcoming both Norcet 8 and RB exam. Okay, type of mastectomy. The simple mastectomy means entire breast is removed. Okay, no sorry, entire breast is removed and no lymph nodes and no muscles are removed. Okay, lymph nodes and muscles are kept intact only. Okay, they have not removed the lymph nodes, not removed the muscles, just a breast tissue completely they have removed means that is called as in the simple mastectomy. Okay, in the MRM that's the modified radical mastectomy. A breast is removed, entire breast is removed, along with that axillary lymph nodes level 1 and level 2. So this level 1 and level 2 axillary lymph nodes plus breast is removed means so that is what you call as the MRM surgery or the modified radical mastectomy surgery. This is only it will comes in your exam. Okay, so among all these steps, so we have to just go through one time, but there is highest chance is the MRM because in clinical settings out of the 1,000 patients of the breast cancer we are doing a 800 MRM and with remaining 200 for the all these type of this surgery. Okay, so because of that the MRM only it will comes in our exams. Okay, so in the breast, entire breast we are removing, axillary lymph nodes we are removing at the level 1 and level 2. Okay, chest muscles are kept intact. Okay, so chest muscles we are not removing in the MRM. Okay, so and the next question, next point is the there is the radical mastectomy means, so the breast removed, lymph node level 1, level 2, level 3 plus chest muscles is removed. Okay, so rarely done in nowadays. Okay, it's very rare surgery we are doing in the radical mastectomy. Okay, so here in the question they have asked, right, entire breast is removing along with the pectoralis muscles we are removing and axillary lymph nodes we are removing. Okay, yes, the breast is removing, the lymph node entire removing, the chest muscles is removing. Okay, so this is what you call as the radical mastectomy. But in the exam this question will come, bacho, modified radical mastectomy it will come in your exam. Okay, so lumpectomy, what is lumpectomy? Only the lump which is there in our breast we are removing. Okay, consider this is the breast. Okay, so in the breast just here the one lump is there. Okay, so we are removing just this lump means we call that one as the lumpectomy. Okay, then only the tumor and small marginal tissue will be removed in the lumpectomy, and it's an breast conserving surgery means we are keeping the breast there itself. Okay, we are not removing the breast, we are keeping the breast there itself and only lump from the breast we are removing. Okay, so that is what we can say, this one is in the breast conserving surgery, very very important. Then comes to the next most important point, the skin sparing mastectomy means a entire breast tissue. Okay, so this is the skin will go inside the breast, entire tissue of the breast will remove but the skin will remain intact. Okay, so the sparing means sparing means, okay, we are keeping it behind only. Okay, so that is what we call as the sparing. Okay, so we are not removing that thing. Okay, except that thing. Okay, skin sparing mastectomy means except skin we are removing the tissue. Okay, that is what we call as the skin sparing mastectomy. In this one breast tissue only and skin is preserved. Okay, only breast tissue is removed and skin is completely preserved. Okay, so often used in the when the planning for a reconstruction. Okay, so after the breast surgery you are planning for the reconstruction means, so we can go for the breast surgery, there is the skin sparing mastectomy. Then comes to the nipple sparing mastectomy, entire breast is removed, breast tissue is only removed. Okay, the nipple and skin is preserved. Okay, nipple also present and the skin is also present, only tissue from inside the breast is removed. So that is what we call as the nipple sparing surgery. Okay, so the sparing words here is the, yes, so we are keeping it as it is and we are not eliminating it. Okay, that is what we call as the sparing. Okay, so here you can see the one kind of the diuretic, that is the potassium sparing diuretic, right? So here the entire fluid, sodium, everything which is eliminating except the potassium. Okay, so potassium is keeping in the body and everything is eliminating. Okay, here is the nipple sparing means nipple we are keeping in the body and rest tissue and surrounding thing we are removing. Okay, so tissue and its margin we are removing. Okay, so then our entire skin and nipple we are keeping as it is. Okay, that's the nipple or sparing surgery. So among all these sir, only two I want to remember. Okay, remember the radical mastectomy and remember the MRM. Okay, very important point. Okay, so hope it is clear to everyone. And if you want a better rank like top 10, top 20, so you can remember everything. If you want to rank in the top 1000, so you can remember those two things. Okay, so here is the next very important question. Okay, so the question is, which of the following is a normal breath sound? Normal breath sound heard most of the lung fluids. Okay, so the breath sound which is normally present and which we are hearing over the entire lung fields. Okay, so what is the name of the that particular very important breath sound? Option A vesicular, option B bronchial, option C bronchovesicular, option D tracheal. But here entire lung field we are hearing a normal breath sound. It means we are hearing a breath sound of the our vesicular. Okay, so option A goes to the correct answer here. Okay, so then comes to the important of the all lung sound and its location, and one very important extra lung sound, that is the tracheal lung sound we will study here. Okay, so look at this image. This is the trachea. Okay, so from this is the our clavicles, and here is the sternum. Okay, here is the manubrium of the sternum. Okay, so here it is the trachea. So if we are keeping the stethoscope directly on the trachea, means that is the tracheal sound. Okay, so if we are keeping the stethoscope over the manubrium on the upper chest, so this is what we call as the bronchial breath sound. What we call this one is in the bronchial breath sound. Okay, if you are keeping the stethoscope in the main branch where the right bronchi and left bronchi is dividing, so if you are keeping the stethoscope here and you are hearing the sound, means that is the bronchovesicular sound. And if you are keeping the stethoscope in the lung fields, okay, if you are keeping your stethoscope or the entire lung fields are hearing for the sound, means so that is what we call as the vesicular lung sounds. Okay, so previously only these three waves are there. Okay, bronchial, bronchovesicular, and vesicular. When we study your word books, only this is there. Now the tracheal sound which was added. Okay, so that's the very important. All you have to know. Okay, the tracheal sound is the directly we are keeping the stethoscope directly on the upper part of the trachea. In the bronchial sound, the lower part of the trachea or directly on the manubrium, we can say. Then bronchovesicular, where the right and left bronchus are dividing. Then the vesicular is the entire lung field. Okay, so this is only not important. This is enough for the RRB. But when it comes to the AIMS Norcet mains exam, he will ask the inspiration is to expiration ratio in the every breath sound, and especially very important points related to every breath sound. The examiner will throw a question on in front of you people. So all you people have to revise it very quickly with me with a special golden points. Okay, so let me take you people to a special explanation. So that is the vesicular breath sound. So this breath sound is heard in the entire lung fields. Okay, so in the entire lung fields this breath sound will heard. Okay, so the very important point, where is the location of the vesicular breath sound? That is the outer lung area or the peripheral lung area, or we can say on the lung fields. Okay, peripheral lung fields, very important. Then comes to the how is the nature of this vesicular sound? It's a soft and low pitched sound, very important. It is in the low pitched sound. Then comes to the inspiratory to expiration ratio. Here in the vesicular sound, it happens like this. Okay, so during the inspiration you will see a major sound. Okay, during the expiration very little sound. Okay, so the very important golden point, the inspiration to expiration ratio comes to the vesicular breath sound is the 3:1. Okay, so it's a very important in the exam. The examiner can give a questions like this when assessing the normal lung sounds in the patient. If here are inspiration is to expiration ratio 3:1, or a prolonged inspiration and short expiration sound you are hearing, and you kept the stethoscope diaphragm on the peripheral field of the lung. Okay, so identify which of the particular lung sound you are assessing. Okay, in the option again the bronchial, tracheal, bronchovesicular, vesicular sounds you will see. Okay, you are keeping the stethoscope or the peripheral lung fields, and you are hearing the a prolonged inspiration, then a short expiration. That is the inspiration to expiration ratio is the 3:1, and most importantly, it's a low pitched sound. Okay, so this is what you call as the vesicular breath sound. Okay, it is normally seen in the normal lung fields. Okay, very important. Then comes to the next most important lung sound, that is the bronchovesicular lung sound. Okay, where it will be the location here. When you will keep the stethoscope on the right and left bronchi division, so this is what we call as the bronchovesicular breath sound. Okay, in the posteriorly it is between the scapula. Okay, the bronchovesicular breath sound anteriorly over the right and left bronchi division, and posteriorly over between the scapular shoulder blade. So this is the bronchovesicular breath sound. Most importantly, study its characteristics. Inspiration to expiration ratio is equal in the bronchovesicular lung sound. How much duration of the inspiration is there? So the same duration of the expiration will be also there. Okay, so the question will come: the inspiration to expiration ratio in the bronchovesicular lung sound is the 1:1. Okay, most importantly, then comes to the next point. Okay, so there are normally heard between the shoulder blades posteriorly and in the major bronchi. Here the right and left bronchi dividing. So here it is the location of the bronchovesicular sound. Posteriorly between the shoulder blades, anteriorly where it is dividing right and left bronchi, very important, and they have the moderate pitch to loud voice. Okay, bacho. So we have studied the peripheral lung field sound, that is the vesicular. This is the low pitch. Bronchovesicular is the moderate pitch, and this one bronchial is the very important high pitch. Okay, so one second please. This is the high pitch sound. Okay, so very important, you people have to know about. Okay, so just we have finished with the bronchovesicular breath sound and its special characteristics. Okay, so the inspiration and expiration is equal here. Okay, inspiration and expiration is equal in the bronchovesicular breath sound. When it comes to the bronchial breath sound, okay, so bronchial breath sound, where I told which happening on the upper part of the chest or on the manubrium or the lower part of the trachea, we can say. Okay, so that is the allocation of the bronchial breath sound. Okay, the bronchial breath sound is the normally heard only over the trachea near the upper part of the chest. Okay, that is on the manubrium. Okay, so we can say only over the lower trachea. Okay, only over the lower trachea, or we can say over the manubrium, and or the near the upper part of the chest, upper part of the chest, lower part of the trachea, over the manubrium. This is the specific point for the bronchial breath sound, and the bronchial breath sound is the high pitched sound. Okay, then comes to the expiratory phase is longer than the inspiratory phase in the our bronchial breath sound. Here the expiration is longer than the inspiration. When it comes to the ratio, it is the 2:1. Okay, only one breath sound where the we are hearing the expiration more than the inspiration. Okay, here the expiration is more. Okay, so in the bronchovesicular, inspiration is equal to expiration. In the vesicular, the prolonged inspiration and expiration. Okay, that is the 3:1. Okay, when it comes to the bronchial breath sound, here the expiration sound is more than the inspiration sound. Okay, so this is very important, and it is the high pitched sound. Then comes to the tracheal breath sound. That is the very important. What I told you people, that is the it is directly heard over the trachea. Okay, it's directly heard over the trachea. So it is in the very important sound here. It is the heard directly over the trachea when you place the stethoscope directly on the trachea. Then it's a very loud sound and high pitched sound. Okay, so it's a very loud sound. Okay, then comes to the next point. The inspiration and expiration phase is equal. Okay, and the duration is equal here. So the sound are harsh and tubular sound. Okay, like a wind blowing through a pipe. Okay, this kind of the this is the pipe, and inside the pipe the wind is the air is moving on. Okay, like that kind of the sound it will come, or the tracheal breath sound. Very important, bacho. There are two equal breath sound are there. Okay, in the bronchovesicular, inspiration is to expiration is inspiration sound is equal to expiration sound. In the trachea, inspiratory sound is equal to expiratory sound. In the bronchial sound, where the expiration is more than the inspiration. Okay, so in the vesicular sound, here the inspiration is more than the expiration. So this is what the characteristics of the different kind of the normal breath sound which will be asked in your exam. Okay, so hope the every point on the breath sound is clear, and here was the our answer. Okay, the normal breath sound heard over the most of the lung fields is the vesicular. Okay, directly over the trachea. Okay, directly over the trachea is the tracheal breath sound. Okay, lower part of the trachea, upper part of the what we can say the chest, and over the manubrium is the bronchial. The bronchovesicular is the main stem of the bronchi. Okay, anteriorly and posteriorly between the shoulder blades. Okay, so this is a very important point, bacho. And all the rapid revision point we have covered on the normal breath sound. Okay, it will strikes in your exams. Don't forget this one. Okay, so the next very important question is the yes. So do read the question till the end completely carefully. Then give your best response in the comment box. I'm waiting for your answer here. A 70-year-old patient has decreased breath sound on the right side. Okay, so what happened? The age of the patient is the 70 year, and he has the decreased breath sound, okay, on the right side. Then the dullness or to the percussion, okay, when the percussion we will do, when we tap the chest field, the dull sound we will get, okay. So then the trachea is deviated to the left side, okay. So the trachea should be in the middle line, okay. It's deviated to the left side, very importantly. Then what may be the expected condition is this? Very importantly, a decreased breath sound is there, one first clue. Then that is the decreased breath sound is there at the right side. Then the second very important clue. Then the dullness on the percussion. The third very important clue. Then a trachea deviated to the left side, means the right side decreased breath sound is there, means where the decreased breath sound and dullness on the percussion means the fluid is filled here, okay. The fluid is filled here, so that is what the dullness we are getting, means in the pleural space the fluid is filled, okay. So that is over the right lung, the pleural space, the complete fluid is filled, okay. That is what the trachea is deviated to the opposite side, the trachea is deviated to the left side, okay. Then the most important thing, the dullness on the percussion indicating the fluid, okay. That is the fluid filled cavity, okay, which is dull, okay. If it is air filled cavity, so that will be a very important in tympanic sound it will come, okay. So air filled empty cavity, it will come as a tympanic sound, okay. So air trapped, like in the emphysema and all, when you will trap, the normally hyper resonance sound it will come, okay. So that is the another condition, okay. So we'll discuss that one also, don't have to worry about that. So now I want to clarify you people, a 70-year-old patient decreased breath sound means that is at the right side of the heart, and there is a dullness means it's clearly indicating that is the right sided pleural effusion is your answer here, okay. That is the most important thing all you people have to understand. Sir, just draw a diagram and show us, sir. Yes, I will show you. This is the x-ray of the patient with a pleural effusion, okay. Note it down here. So this is the I am talking about this x-ray. Let me take another pen color. This particular x-ray I am talking about, okay. So this is the right side of the chest and this is the left side of the chest, okay. Focus over this x-ray. Here there is on the normally chest should be like this, but here it is this, till this only we are getting the lung, and this entire field is completely white, okay. So where there is a fluid is filled, okay. Consider where the fluid is filled, so in the x-ray it will show the white, okay. When this particular thing which is the air, okay, which is air, so it will show as a black in the x-ray, okay. So here the fluid is filled means a pleural space which is completely filled with fluid and which created the pressure and it moved the lung upward, okay. So the lung is moved upward here. Then when you see this particular angle, this sharp angle, okay, look on the above x-ray, this is the sharp angle. So this one we call as the costophrenic angle, okay. So it should be normally sharp. The costophrenic angle normally should be sharp. When there is a blunting in the costophrenic angle, okay, look at this particular x-ray, the angle is completely blunt here, okay, blunt here. So the costophrenic angle is blunt means it indicating that is the, on the x-ray it indicating the, it is the pleural effusion, okay. So it is blunt here, most important thing. And if this side particular effusion is there means it creates the pressure towards the mediastinum, and the mediastinum shift will happen to opposite side, and the trachea shift happens to the opposite side, okay. So in our x-ray, just a second please, on emergency call. Okay, so it's very important. So when you see the x-ray, so it is very easy to identify. If it is filled with the fluid means it looks like white, okay. So when it is filled with the air means which looks like black, okay. If it is looking very black means that is the another condition, that is the very important what you can say, the air filled pleural cavity, yes, that is the pneumoperitoneum, sorry, pneumothorax, okay. So that is the very important things we will see with X-ray in the next upcoming question. Don't have to worry about that one. Okay. So hope it is clear to everyone. And what I told, the mediastinum and trachea will divide to the opposite side. Okay. So the blunting of the costophrenic angle. Okay. Here it's the area is now completely fluid white. So there is a fluid filled. So fluid filled pleural cavity we call as the pleural effusion. Okay. And when we tap over the fluid filled cavity, it will show the a dull percussion sound, and trachea is evident to the right side. Right side is the option breath sound. Why? Because option breath sound high here. Why means, look at this particular image. So till this particular point, the lung should be there normally. Okay. So because of the fluid filled cavity, the lung is moved upward, and now I am keeping the stethoscope here. Means there is no lung only. Means there is no sound of the air entry. So it will show the diminished breath sound or the option breath sound in the pleural effusion. Okay. And same condition in the hemothorax, pneumothorax also. So I will explain that one. Don't have to worry. Okay. So there is decreased breath sound, and at the right side, decreased breath sound means the right sided pleural effusion happened, and dullness means the water have accumulated. Trachea diverted to the left side means the opposite side, the trachea is diverted. Hope it is clear, and the answer goes to the option B. That is the right sided pleural effusion is the correct answer. Okay, so let me quickly revise all the important abnormal breath sound where the diminished or the decreased breath sound is the most important thing. Okay. The diminished or the decreased breath sound is the most important thing here. We can see that is the seen in the pneumothorax and pleural effusion and the hemothorax and lung collapse, or we can say atelectasis. Sir, how, sir? Let me explain quickly, properly, perfectly to you people. Okay, just a second. One important emergency call is there. So, yeah, okay, it's fine. Okay, so yes, we'll start up the class. Here, a diminished or the decreased breath sound means you will see in the pneumothorax, pleural effusion, hemothorax, and lung collapse of them. So let me quickly explain this one with the image so you people will get complete clarity here. Okay. So what I told, this is the normal lung field. Okay. And over the normal lung field, so here we are having a pleural cavity. Okay. So this is the lung and this is the pleural cavity. So when there is the air accumulation or when there is in the fluid accumulation, it creates the pressure on the normal lung tissue, and our lungs will start move upward. Okay. So this lungs will start move upward. Then comes to the lungs become this much only. Okay. And rest all the this particular space is filled with the blood, we can say. It may filled with the blood, so that is what we call as the hemothorax, and it may filled with the fluid, we can say the hydrothorax or the pleural effusion. Okay, if it is filled with the air, that is the pneumothorax. Okay, so here when the when you inspire the air through the trachea, it will come to the bronchi and it will come till this particular lung part only. Okay, so it will not come till the complete distal part. Okay, so when you will keep the stethoscope over the this particular lung, so you will get the no breathe sound. Okay, so you will get the no breathe sound, or you can say the diminished breath sound, the diminished breath sound, or we can say the absent breath sound. All is one only. Okay, so when we will see this one, we will see in the pneumothorax, pleural effusion, hemothorax, and lung collapse. Sir, what about the pulmonary edema, sir? In the pulmonary edema also we have heard, sir, there is fluid accumulation. But here also in the pleural effusion, fluid accumulation. Sir, we have studied in the pulmonary edema, we can get the crackles sound, sir. Sir, the simple difference is this much only. In the pleural effusion or the hydrothorax, will accumulation of the fluid in the pleural space. But in the pulmonary edema, you people will get the accumulation of the fluid inside the lung. Okay, so in the pleural edema, accumulation of the fluid will be there inside the lung. Okay, so when you will take the air inside the lung, okay, it will move through the fluids. Okay, it will move through a fluid. Okay, then when the air is moving through the fluid means it will create the bubbling sound. Okay, so that is what we call as the crackle sound. Okay, so in the pulmonary edema you will see the crackle sound. Okay, pulmonary edema you will see the a bubbling sound or the crackle sound. Okay, so in the pleural effusion we will see the absent sound or the diminished breath sound. Okay, so this is what we have to differentiate very importantly. This is the crackle sound or the bubbling sound. So hope it will be clear to you people. So the next is the pleural friction rub. Okay, so what is the friction? When two things rub together, so that is what we call as the friction. Where in the pleural cavity also we are having the two type of the pleura. One is the parietal pleura, one another one is the visceral pleura. Okay, so the pleural layer which is there towards the lung, that is the visceral pleura, and which is there outside, that is the parietal pleura. So if there is any infection and inflammation of this pleural cavity, we call this one as the pleuritis or the pleurisy. Okay, so the inflamed two pleural lungs rub together. Why it's rub together? Why? Whether if I am inspiring the air, my heart will get inflate, deflate, right? No. Why? Because nothing will go inside the heart if I inspires the air. Okay, but I inspires the air means the lung will expands and collapse. Lung will expands and comes to the normal. So when the lung is moving continuously means the layers around the lung also moves continuously. So those layer if got inflammation means, so when inspiring, so it will rub together. Okay, so the pleural effusion will be seen when there is on the inflamed two pleural surfaces are rubbing together, especially in these condition called as the pleuritis or the pleurisy. Okay, so pleural friction rub will be seen in the pleuritis or the pleurisy. Very, very important. Then comes to the next important sound, that is the stridor. Okay, so consider this is the trachea, and here we are having the epiglottitis. Okay, so epiglottis. So if this epiglottis is inflamed, or if this laryngeal box or the laryngeal edema is there, means in short we can say upper airway obstructed. Upper airway obstructed. So in the upper airway obstruction, because of the difficulty in the air entry, especially during the inspiration, so if there is a sound which is coming high pitched, loud crowing sound, okay, so if it is coming during the inspiration because of the upper airway obstruction, so we call this one as the stridor. Very, very importantly, this classical indicates the laryngeal edema or something accumulation over the upper airway and foreign body. So the croup in the children, that is the laryngeotracheobronchitis. Okay, in the children's we call as the croup. So if the croup in the children's, if laryngeal edema or foreign body in the upper airway, so if there is any upper airway obstruction, you will get the a very important sound that is called as the stridor. Okay, so in the question, if the examiner given a stridor sound is coming, always think about the upper airway obstruction and choose that answer which is related to the upper airway obstruction. What I told here, that is the crow, laryngeal edema, and foreign body. And one more, that is the epiglottitis. Okay, so the infection, inflammation of the epiglottis. Okay, so this is very important point. So again, I am writing here. It's a very, very important one. Okay, so the next one is the rhonchi. Okay, so next very important point is the rhonchi. It's in the low pitched sound. Okay, we can say the low pitched rattling sound during the exhalation or during the expiration. We'll see. So the rhonchi will be seen in the bronchitis and some pneumonia also. Okay, so it's not in that kind of the specific one, and it's not that much important. That just for the differentiation purpose, I told related to the rhonchi. Okay, it's not that much important, but the stridor is most important. Diminished breath sound is most important. Then the pleural friction rub is the most important, and this wheezing is the very, very important. Wheezing is a wheezy, musy, writing sound. Okay, so there is a high pitched musical sound which is coming. Okay, so wheezy is the musy. Okay, the high pitched wheezing musical sound. Okay, which is coming like whistle. Okay, so when you will do the whistle. Okay, so like that the sound is coming. Okay, this one is a classically seen in the asthma, the thousand star important point. Okay, it's on the thousand star important point it will comes. Okay, where we will see the wheezing in the asthma, sometimes COPD, bronchitis also, but classically we will see it in the asthma. Okay, so very importantly it will be seen during the expiration. Okay, so why this COPD, bronchitis and asthma all are the obstructive lung diseases. Okay, so the inspiration is the active process. All of you know the physiology of the respiration, where the inspiration is the active process, where I need to initiate the inspiration. Okay, like I can take, but the exhalation is the passive process. It automatically happens. Okay, there is no need of the anything, but the exhalation happens automatically. But to take the air inside, the energy required. So inspiration is the active process, exhalation is the passive process. Where in the airways obstructed in the asthma and in the COPD and in the bronchitis, during the inhalation, the airway will get expands and the air will go inside. Means there is no sound, but while coming the back, the air will come by the obstructed pathway. So where the wheezing sound will created during the exhalation or during the expiration. Okay, so very important. So the during exhalation sound will wheezing sound will come during the exhalation. Okay, so it's classically seen in the asthma. So again after the exam I will come with the screenshot, but so these questions will strike in the exam or not. Yes, it will be struck in the exam. The next one is the a very important point. That is the crackles or the rails. I told already, when the crackles or the rails means, so something is there. Consider this is a bucket filled with the water. Okay, so I'm keeping the pipe, I'm pushing the air inside. So where there is a double bubble sound will come, so that kind of this sound will be generated, that is called as the bubble popping sound. Okay, so which will be seen when the airway moves through the fluid, like as I told in the pulmonary edema. Okay, so the entire lung is filled with the fluid. Okay, so in the pneumonia entire lung is congested with the fluid and pus. Okay, so when the air will come inside, it will move through a fluid and pus, so the crackles and the rails will be heard here. Okay, very important. When it occurs means mostly during the inspiration. Why? Because so to happen the crackle sound, the air should move through the fluid. Okay, so the crackles happens during the inspiration, and mostly it apparently indicating the lung is filled with the fluid like the pneumonia and left sided heart failure. Okay, so left side heart is failed means left ventricle is not functioning, means the fluid is congesting in the left atrium. Okay, the fluid is congested in the left atrium means fluid is congested in the pulmonary veins. The fluid is congested in the pulmonary veins means the fluid is congested in the lungs. Okay, so the fluid is congested in the lungs, the air is entering means the crackle sound will develop. Okay, so if the patient is known case of the left sided heart failure, now the crackles are started means what it indicates, it indicates the worsening of the left sided heart failure. So that is the most important and very important point you have to consider and give your best answer in the upcoming exams. Okay, so hope it is clear about the all type of the abnormal lung cancer, but lung sounds bachcho. So whatever the important thing I have delivering in front of you people, it's up to you people whether you want to utilize or you want to leave it. Okay, so yes, just at least take a screenshot and revise 2 to 3 times. It will help you people definitely. Okay, so the next very important point question is the this one. Okay, so which of the following statement about the proper size of the bladder in the blood pressure cuff is correct? Okay, so among given the four option, okay, which of the size related to the blood pressure cuff bladder is correct? Okay, so just let me clarify what is blood pressure cuff and what is the bladder. Okay, so this is the blue one what you are looking here. So this one is the entire blood pressure cuff. Okay, so inside this particular portion which white in color, so which is the bladder, we can say this one is in the bladder. Means when we will tie this particular cuff to the arm of the patient, so that when we will inflate the uh, sphygmomanometer with that inflating bulb. Okay, so the air will inflate only this bladder only. Okay, not in the entire cup. Okay, so air will inflate in this particular bladder. Okay, so the bladder should be at least 80% of the this particular our arm circumference, and the width should be, it should at least cover the 40% of the arm circumference. Okay, so the width of the bladder is 40% at least, and most importantly, circumference of the bladder is the 80% at least. Most important. Okay, found these particular options where it is. Option A is telling a bladder length is 40%. No, bacho. The bladder length or the bladder circumference should be 80%. So I am eliminating option A. Then comes to the option B. The bladder width should be 80%. No, the bladder width should be, a bladder width should be 40%. So option B is also not correct answer. Then comes to the option C. The bladder length is 80% of the arm circumference. Yes, it's correct. And the bladder width is the 40% of the arm circumference. Right. So the length of the bladder is the 80% of the arm circumference, and the width of the bladder is the 40% of the arm circumference. Very, very important. So this is the 40% width and 80% length. Okay, so very, very important point. All you people have to know, understand, and give your best answer. Here is the rapid revision of the few points related to the blood pressure, so which will be very much helpful to you people. Okay, so for the accurate BP measurement, bladder length should be 80% of the arm circumference, and bladder width should be 40% of the arm circumference. A golden point. This is the golden point. Then comes to the next very important point. While using the wrong size cuff, you can indicate the this particular reading. Okay, so you are using the too small BP cuff, means it will give the falsely high blood pressure. Most important, you are using the too large BP cuff, means it will give the falsely low blood pressure. So this is the most important, very important, bacho. So it will be very, very important. Using a wrong size cuff leads to the inaccurate reading, where the small cuff is giving the high blood pressure and a large cuff is giving the low blood pressure. So it's very important. Okay, so and few more things. Okay, the errors and effects on the BP reading. Look at this one. If the cuff is too small or the narrow, both are same. The cuff is small and narrow. Okay, so narrow small means it gives the high BP. The cup is too large and wide, it gives the low BP, opposite side. Okay, but when you, while checking the blood pressure, the arm is above the heart, means it gives the falsely above the heart, it gives the falsely high BP. Okay, above the heart, below the heart, it's high BP. Okay, and arm is above the heart, it will give the low BP. Okay, very, very important, bacho. It's above the heart, low BP, below the heart, high BP. Okay, so this is the again a 100-star, very, very important point. Okay, so don't miss this all things, because this is the a golden content what we are delivering here. Okay, the cup of the size is too small, high, too large, low. Okay, above the heart, high, so below the heart, high, and above the heart is low. So take a screenshot of this one, reverse at least 2 to 3 times, so it will be very much helpful to you people. Okay, so then the next very important point is like this. Okay, the normal BP for the adults. What is the normal BP for the adults when it comes to the important points? The systolic normal BP is the 90 to 120 is the normal, and diastolic is the 60 to 80 is the normal. If you want to one only single reading, this is the 80 to 80 by 120 by 80 mm, which is the normal BP. Okay, bacho, in the last Norcet, there are the options like this to identify the normal blood pressure, like less than 120 by 80. Okay, so that is again 125 by 89, like these options were there. So many people will get confused. Okay, the correct answer is always a normal blood pressure should be less than. Okay, so that is the less than 120 by 80. Okay, according to New American Heart Association guidelines of the hypertension. So here the normal BP is categorized under the less than 120 by 80. So this is the correct answer. The word less than, where it will come. So there that will go your priority answer. Okay. So this is the reason why I have brought this particular points here to clarify the thing before going to the exams. Okay. So yes, is that clear? Yes. So to do fatafat thumbs up if it's clear to everyone. Okay. So always normal blood pressure best answer is the less than 120 by 80. So and the all categorization of the hypertension we have discussed in the previous class of the updated session, where I have conducted one special class on the all the updates, where I have given the very important points on the TB regimen newly updated by the government of India, and a Muskan program newly launched by the government of India, and some of the most important programs, and this new American Heart Association categorization of the blood pressure. So everything we have discussed there in the updated class. Okay, if you want that one, so I will give you that updated class link in the comment box at the end of this class. Okay, don't have to worry. If everyone is clear with this particular point, so please do thumbs up for effort. Yes, a very nice of you all. So we'll start the next point, that is the normal BP for the neonates. Okay, systolic is 60 by 60 to 90, and diastolic is the 40 to 60. The one single best answer is the 80 by 40. Okay, so remember this one, normal blood pressure of the neonate is the 80 by 40 mmHg. So this is the very important. So it came many time in the exam related to the neonate and related to the adult. Okay, so many people will do mistake by choosing the more than less than point only. I know you people know the answer, it's an 120 by 80. When it comes to the point of the options, like it's more than 120 80, less than 120 80, then your dimag will circulates like this. Okay, so don't rotate, the master is here, don't have to fear. Okay, the next question is like this. Okay, so the question is, a 68-year-old parents with complaints of the dizziness. Okay, a 68-year-old male presents with the complaints of the dizziness. His BP is 160 by 90 mmHg. Based on this, what is the pulse pressure and what does it suggest? Okay, so option A, 50 mmHg normal, 70 mmHg widened pulse pressure, 30 mmHg narrow pulse pressure, then 90 mmHg extremely widened pulse pressure, and it is the medical emergency it is showing. So what is the correct answer? So these kind of the calculation portions, very easy calculated portions you will get in the your particular exams, and you people will get confused for this one. Okay, it's very simple. Just the BP is given here. You need to calculate the pulse pressure. What is the pulse pressure? The pulse pressure is equal to systolic blood pressure minus diastolic blood pressure. Okay, so the pulse pressure is the SBP is the 160, DBP is the 90. So your answer comes here as the 70 mmHg is the pulse pressure. Okay, normal pulse pressure is the 40 mmHg is the normal pulse pressure. Means here it is the more. Okay, sir, how 40? How 40 means normal SBP is 120, normal DBP is 80. So 120 by 80 is the 40. So this is the normal pulse pressure. Okay, so this is the normal pulse pressure. Okay, when it comes to the 70 mmHg, so it's a widened pulse pressure. 70 mmHg, that is the widened pulse pressure, and possibly it's indicating the atherosclerosis and some other diseases. So let me clarify what is the widened pulse pressure, what is the narrow pulse pressure. Before going to that one, identify this particular triad what I have given here. Okay, bradycardia with bounding pulse, bradycardia with bounding pulse, and hypertension with, that is the systolic blood pressure is raised with widened pulse pressure. Okay, so widened pulse pressure and irregular respiration. Okay, so hypertension, that is the systolic hypertension with widened pulse pressure, irregular respiration, and bradycardia is there. So this is what we call as the Cushing triad. So where we will see the Cushing triad. Can anyone able to wants to answer? Sorry, not able to, just want to. Okay, because you everyone are confident and you everyone is eligible to give a mains exam, means yes, you everyone are fit to crack the exams. Okay, if anyone wants to answer for the Cushing syndrome, where we can say yes, that is in the raised intracranial pressure. Okay, so that's the very important point. The Cushing syndrome will seen in the raised ACP in case of the mainly in the head injury. Okay, mainly in the head injury we can face this particular Cushing triad. Okay, so bacho, where I told here there is increased SBP with widened pulse pressure. Okay, it means it is not indicating both diastolic blood pressure and systolic blood pressure is high. It's indicating just the SBP is high. Okay, so SBP is high. Consider. Okay, now the SBP is 160 by 80. You consider. Then calculate the pulse pressure. So 160 minus 80 is the 80 is the pulse pressure. Okay, so 80 is the pulse pressure means it's a large pulse pressure, or we can say the widened pulse pressure. Okay, why? Because the normal one pulse pressure is the 40. Okay, here it is coming the 80. So it's a widened pulse pressure. Okay, so let me clarify again. Cushing syndrome or in the raised ICP, which what is seen? Okay, that is the isolated systolic hypertension, which leads systolic hypertension, which leads to the increased pulse pressure. Okay, so that is the widened pulse pressure with the raised SBP will be the very important. So that is the hypertension, that is the systolic blood pressure is increased and pulse pressure is widened. Okay, so this is how why I have brought this question here, and all important related things I am discussing in the Cushing syndrome wide pulse pressure we will see. Okay, so if just I have told that the pulse pressure is high and the systolic BP is high. The systolic BP is high means the heart is contracting very strong and the pressure is excreting on the carotid arteries and carotid sinuses. Okay, here we are having the baroreceptors. Okay, there is baroreceptors are the pressure sensitizing receptors which is there over the carotid artery and sinus. So when the more pressure will comes to the baroreceptors, a baroreceptors sends the signals to the brain and it tells, sir, there is excessive pressure is there on your artery, sir. Okay, then the brain will activate the parasympathetic nervous system and it sends the signals to the heart. Yes, contract slowly. Okay, then the parasympathetic nervous system is activated means the bradycardia will be seen and the heart rate will be decreased here as a response of the increased BP and baroreceptor stimulation. So this question recently asked in your FMG exam. Okay, so why there is bradycardia in the Cushing syndrome means by activating the parasympathetic nervous system by the baroreceptors, the bradycardia happened in the Cushing syndrome. So this is the trending now. Okay, so this is the trending portion now. Okay, very important. Then comes to the irregular abnormal respiration will be seen. Why it will be seen? The respiratory regulating center, which is the medulla oblongata. Okay, so what is the respiratory regulating center? The medulla oblongata is also called as in the respiratory center. Okay, so which is there in the brain here. Okay, when there is the rise in the increased intracranial pressure, when there is the intracranial pressure is raised, it creates the pressure over the our medulla oblongata, the pressure over the medulla oblongata, which makes the respiratory regulatory center to damage and it becomes the irregularly respirations we will see here. Okay, this is the classical scene in the Cushing triad of the head injury. Most important, bacho, remember the widened pulse pressure will be seen in the Cushing triad patients in the head injury. Okay, and these all Cushing triad sign symptoms are the late sign of the head injury. Okay, these are all the late sign of the head injury. Most important and very important. Okay, so then we are again getting the three very important symptoms. That is the isolated systolic hypertension. That is the with narrow pulse pressure. Then the jugular venous distension and muffled heart sound. So here, what is the name of this triad? Okay, where the triad we are getting the muffled heart sound and isolated systolic hypertension, hypotension and increased jugular venous pressure. Okay, so this is the triad of the our Beck's triad. Where we can see this one? We can see this one in the cardiac tamponade. Here, just a isolated means separated systolic hypotension is there. Means only the systolic BP is reducing here. Okay, so consider now here the SBP is decreased. Okay, so means the now blood pressure is the I will keep the diastolic blood pressure as the normal and just the SBP is the 90. That is the only systolic isolated systolic hypotension is there. Okay, So the now pulse pressure I will calculate. The pulse pressure is equal to SBP minus DBP. Okay, SBP is 90, DBP is 80. The pulse pressure is only 10. Okay, so 10 means it's a narrow pulse pressure. So in the cardiac tamponade, we are getting the a narrow pulse pressure. Very very important point. Okay, so in the head injury, we are getting the widen pulse pressure. In the cardiac tamponade, we are getting the narrow pulse pressure. Okay, so this very important isolated systolic hypotension, jugular vein distension, and a muffled heart sound. So this is the classical indication of the Beth's triad. We will see this one is in the cardiac tamponade. Sir, what is cardiac tamponade? Yes. So let quickly revise this one. A very very important point. So let me make a simple diagram for you all. Okay, this is the heart you people consider. Okay, so around surround of the heart, we are having the pericardial layers. Okay, so in the pericardial layers, there is suddenly a rapidly accumulation of the fluid more than 250 ml. Okay, so the rapid accumulation of the fluid more than 250 ml. Okay, around surround of the heart. So this is what we call as in the cardiac tamponade. Okay, the cardiac tamponade. Slowly, progressively, small amount of the fluid is accumulating means we call that one as the cardiac effusion. But here the rapidly happening, the rapidly accumulating, and the fluid is more than 250 ml. Okay, so this is what you call the cardiac tamponade. Okay, so when there is a cardiac tamponade, the fluid is accumulated here. It creates the pressure on the heart. Okay, it creates the excessive pressure on the heart. Means now the blood, it should return to the heart from here. Here the pressure is there on the heart, means the complete vein, the superior vena cava will not empty in the right atrium. Means the right atrium is having the less space because of the pressure. Means the blood will remains in the superior vena cava and the blood remains in the our jugular vein. Okay, so the jugular vein will get distant here. Okay, so that is what we call as the jugular venous distant. We will see. Okay, and so as I told, here is a pressure on the heart. Okay, so here the blood is not coming properly to the left ventricle because it is having the less space, and it is not properly relaxing because of the pressure. So not relaxing means not feeling properly. So it will contract the blood, heart. Okay, means the less blood will go. The less blood will go means the systolic BP will get decreases. Okay, that is the systolic hypotension. Okay, jugular venous distension, systolic hypotension. Okay, so that is what we call here as in the systolic hypotension. Okay, so and as I told, our heart is completely surrounded by the fluid. Now I want to hear the heart sound by the stethoscope. Means the heart is beating. Okay, and heart is beating here inside, and the sound is coming by crossing this particular water. Means there is the muffled sound will come. Okay, so this is the muffled heartbeat. Okay, the muffled heartbeat, systolic hypotension, and the jugular venous distension. This is the classical triad of the cardiac tamponade. The name of the triad is the Beck's triad. Very very important. It will be definitely helping to your exam. Okay, so hope it is clear to everyone, and the answer is here. So in the Beck's triad, we are getting the only systolic BP is decreasing, and because of the only decreased systolic BP, okay, we are getting the pulse pressure low. So that is what we call as the narrow pulse pressure. We'll see in the cardiac tamponade, most important to your upcoming exams. Okay, so the next one is the here. The simple question, scenario based question again. Yes, a patient with a blunt chest trauma presents with the hypotension, jugular venous distension, and muffled heart sound. Yes, if these three important classical triad symptoms are coming, means it's in case of the cardiac tamponade. Okay, so which of the following finding would best support this suspicion? Okay, so we are suspecting that the hypotension is there, the jugular vein is distended, and the muffled heart sound is coming. Okay, so now we are suspecting the patient is of the cardiac tamponade. And one more important classical sign of the cardiac tamponade, it will come. So where we will where it will support that it is the cardiac tamponade. Okay, so which symptom is that one? Okay, option A is telling elevated ST segment, it's not related, and bradycardia, it's not related. So hypotension is there. Okay, bradycardia will be not be here. Okay, so because of the hypotension, there is the tachycardia, we can say. Okay, because of the hypotension, there is a tachycardia. We'll see in the a very important cardiac tamponade. Okay, so the next one is the bonding pulse. Because of the hypotension, there is weak pulse. Okay, weak 30 pulse we'll see in the cardiac tamponade. Okay, so then comes to the only one which is remaining, that is the pulsus paradoxus. Sir, what is pulsus paradoxus? Pulsus paradoxus is when I will take the deep inspiration. Okay, so these are my lungs. These are my very two important lungs, and in between the lungs there is a space. This is the mediastinum space, and here is the heart. Okay, so when I will take the inspiration deeply, okay, so now this heart is enlarged because of the it is filled with the fluid around it, and I am taking the deep breathing. Okay, so again the lung is expanding, and already heart is big, and again the lung is expanding, and lung is putting the pressure on the heart, means at the inspiration deep, so it will create the pressure on the heart. That time the systolic blood pressure will decreases more than 10 mm of Hg during the inspiration. So that is what you call as in the pulsus paradoxus. So this is the classically seen in the case of the cardiac tamponade, and in a case of the our restricted pericardial effusion. Okay, so what is the pulsus paradoxus? Pulsus paradoxus is a drop in a SBP more than 10 mm of Hg during the inspiration. Okay, so we can see this one in the tap cap. What is the tap? T here is the tamponade, A here is the asthma, P here is the pulmonary embolism, then C here is the COPD, and P here is the last one, constrictive pericarditis. So the simple pathology behind this one is the yes. Simple pathology behind this pulsus paradoxus is the pressure on the heart. The pressure on the heart, it may be because of the accumulation of the fluid around the heart, or it may be because of the hyperinflated lungs. Where in the asthma, we will see the hyperinflated lungs because of the air is going inside, and there is restriction in the exhalation of the air. So the air will trap inside. Okay. So because of that only, the most common complication of the asthma, most common complication of asthma, the most common complication of asthma is the emphysema. Okay, our emphysema is the most common complication of the asthma because the air will go inside and it will get trapped here. So air is going inside. Okay, so because of the severe asthma, the air is going inside because of the blockage in the airway. So air is not coming outside. So the lung will get hyperinflation. So when the lung will get hyperinflation, it puts the pressure on the heart, and again when we inhale the air, so it will again create the more pressure on the heart. So the more than 10 mm of Hg of the blood pressure is decreasing during the inhalation, so that causes the pulsus paradoxus. Okay, so it is classically a clear classical sign of the cardiac tamponade, and it is also seen in the emphysema, it is also seen in the asthma, it is also seen in the COPD and pericarditis, most importantly. Okay, but the question will come according to the this particular cardiac tamponade only. So don't forget the pulsus paradoxus. Last time in the mains exam, there is a question to match the things, okay, related to the pulsus paradoxus, pulse pressure and a mean arterial pressure, where you have to cross match the everything and give a answer there. Okay, so that is what I am teaching the everything in that much details here, because it's an important, and it is came very consistently in the exams. Okay, so that is what I'm explaining this one very perfectly. So if I hope it is clear to you people. Okay, so during the deep inhalation, the SBP is decreasing more than 10 mm of Hg. That is what you call as the pulsus paradoxus. It happens because of the pressure on the heart. It may be due to the cardiac tamponade, or it may be due to the hyperinflated lungs. So now the concept is clear here. Okay, so the next point is very important. So on the our stethoscope. Okay. So let me clearly highlight two, three things on the stethoscope and move on. Okay. So these are the earpieces of the stethoscope, and here's the ear tubings. Then this small part we call as on the bell of the stethoscope, and this large coin shape large part we call as on the diaphragm of the stethoscope. Okay, so the question comes, okay, why we have to use the bell, and sorry, where we have to use the bell and where we have to use the diaphragm of the stethoscope. Okay, so first we have to know which is bell and which is diaphragm, then only we can give the answer correctly. Okay, so bell is the this small coin one. Okay, and diaphragm is the big coin one, so that is the diaphragm. Okay, so where we have can use to see the diaphragm, many of you have noticed it in our hospital settings where the doctor will come for the rounds and he will take a stethoscope, and the big coin one, that is the diaphragm, he will keep over the lung. Okay, because the lung sound is the high pitch sound. Okay, and on the abdomen he will keep and he will assess for the bowel sounds. Okay, the bowel sound also a high pitch sound. Okay, but so the diaphragm or the big coin one, so we have to use for the hear the a high pitch sound. Okay, so why we have to use the diaphragm, where we have to hear it for the high pitch sound, and for the bell sound we have bell sound, so this bell is we are using for the low pitch sound. Okay, so where we will hear the low pitch sound, so all of you know that. So first S1 and S2 are the hard sound, which is high pitch. That is what we call as the lub lub dub dub. Okay, not lub lub dub dub. It's still lub dub. Okay, that is the S1 S2 S1 S2. So if you are keeping your ear directly to the chest of the someone, you can hear the hard sound because that is the high pitch sound. Okay, so the high pitch sound we can hear to the our diaphragm. Okay, the S1 and S2, so we can hear directly to the diaphragm. But the S3 S4, there is the S3 is the ventricular gallop, S4 is the atrial gallop. Okay, so the ventricular gallop is the S3 and atrial gallop is the S4. So these are the low pitch sound. Okay, these both are the low pitch sound. So to hear the S3 S4 we have to use the this small coin one, that is the bell of the stethoscope, most important. Okay, then to hear the carotid bruit, what is the bruit? Bruit is the turbulence sound which comes when the blood flows through a particular stenosed or the blocked particular artery. Okay, consider this is a carotid artery, and here some plaque is developed. Okay, some thrombus or the plaque is developed. Now the blood is coming and flowing this through this particular narrow portion. Now here the turbulence sound will produce. Okay, so this turbulence sound we call as in the bruit. Okay, so again here we have heard the bruit. Bruit is the a sound where it will comes when the blood flows through the AV fistula. Okay, so for the dialysis purpose we have created the arterio and venous fistula, means the connection between the atrium and venous. So when the blood flows through that, the bruit will come. Okay, so to hear that bruit and to hear the carotid bruit, to hear the bruit sound we have to use this bell of the stethoscope, most important point. Okay, so to hear the high pitch sound like abdominal intestinal sounds, lung sounds, and pericardial friction rubs and bowel sounds. So these all are the we can see and hear by the using the diaphragm. Okay, so most important and most important question. Okay, so one more important thing consider regarding the AV fistula. Okay, consider this is the hand point. So here is a vein from this side. Okay, and here is the artery from this side. Okay, so just we have created a fistula, means we have created the opening here. So whether it is functioning or not, means we have to check for the two things. One is for the thrill and another one is for the fruit. So which one you will auscultate, which one you will palpate? Yes, the thrill should be palpated. Okay, palpate for thrill and auscultate for the brood. The auscultation sound, the brood sound is coming, means this is normal. There is no any block. It is functioning normal. When you will palpate, so when you will palpate, the thrill will come. So if you are feeling the palpation, the thrill, so that is the AV fistula is normal. If in case absent of the brood and thrill, absent of the brood and thrill, which indicates the arteriovenous fistula is blocked. A very important extra point to you people. So remember and don't forget the use of the bell and diaphragm, which is important to you people. Okay. So the next one is the yes, some important points on the measuring the blood pressure. Measuring of the blood pressure, we have where we have seen some very important point. What is the normal blood pressure in the adults? What is the normal blood pressure in the neonate? What is the important point that is related to the pulse pressure and pulsus paradoxus. Okay, so then comes to the isolated hypotension and hypertension backstride cardiac stride. Okay, so then comes to the very important points related to the blood pressure, where it will come high low, everything we have seen. So here is the again some important high yield golden points. Okay, some in some area, in some situations of the clinical setting, where we have to avoid the measuring the blood pressure. Okay, so what are the things and where we have to avoid the measuring the blood pressure? So this is the golden points again for you people. Okay, so contraindication to measure the blood pressure in the arm is like if you have any AB fistula on the right arm, so don't take a blood pressure from the right arm. Take from the left arm. Okay. If you have the fistula on the left arm, take the blood pressure from the right arm. Okay. So wherever the AB fistula is there, that side don't take the blood pressure. Okay. Very important. Then comes to the if right side mastectomy happened, don't take a blood pressure from the right hand. Okay, take it from the left hand. If the left side mastectomy happened, take a blood pressure from the right side. Don't take a blood pressure from the mastectomy side. Okay, so why? Because of this some lymph node excision or the lymph node removal from the mastectomy, the fluid is not drained. Okay, so here again we are creating the pressure, means it creates the pressures on the lymphatic fluid, and there is again increasing the pressure on the lymph nodes, and again there is a chance of the lymphedema will be there. So that is the reason wherever the mastectomy is there and wherever the lymph node we have dissection done, so that side don't take the blood pressure. Okay, so then comes to the third point, recent trauma surgery on the arm. Okay, so recent rod fixation is there in the arm. Okay, recently trauma happened to the arm, don't take the blood pressure from that same time, same type of the hand. Okay, take from the another hand. Okay, then some cast is there, dressing is there, avoid that one. Okay, consider here the IV cannula is there in the our particular right arm. Okay, so the blood transfusion is going on, the IV fluid is going on, don't take the BP from this hand, take a BP from the opposite hand. Okay, so if the infusion is there, a blood pressure is there, okay, don't take the BP from the same hand, take from the another hand. Okay, some consider the right hand is paralyzed. Okay, don't use the right hand for the BP measurement. Okay, use the another hand for the BP measurements. Okay, so this is the very important golden points to you people. Okay, so which is the very much helpful to you people here. Then comes to the next most important question, that is the which of the following is considered as the most accurate or the ideal method of measuring the core body temperature in a clinical setting. Okay, so which one is considered as the ideal method of measuring the core body temperature in the clinical setting? Most important thing. So whenever the question comes to the core body temperature and ideal and most accurate, the single answer goes to the option C, the rectal thermometer is used, or the rectal route is the most accurate method or the most ideal method and to measure the core body temperature. So that is the option C goes to the correct answer. Okay, if the examiner is using the word the most commonly used method of taking the blood pressure, taking the temperature is the our axillary is the most commonly used. Okay, then the least accurate method is the axillary one. Okay, so most preferred in the preferred preferably used in clinical settings. Okay, in the clinical settings most preferably used is the axillary one. Okay, so most important point. So this is the simple questions and very important classification and some of the very golden questions, concept, everything we have discussed in this particular today's class. In the next class again we will discuss the continued part of this one, where I am going to grab those a core point of your preparation. Okay, so where it will be helpful to you people for your upcoming exams. Okay, so that is for the upcoming Norcet 8 exam mains and for the RRB nursing superintendent exam. these classes applicable to the both important exams, so that will be helping, and that will be helping to decide your rank in your upcoming exams. Okay, so if any one of you are preparing for the RRB nursing student exam, we have a best plan to you people. Okay, so the plan is the RRB Vande Bharat test series. So among this test series, we are giving the 30 very important tests. Okay, among these already 22 to 25 tests are already uploaded. Remaining 5 we are uploading on a day basis. Okay, so you can practice the fully planned test series which is there for you people in your which will definitely helps you to practice the non-nursing things and nursing things. Okay, especially the high yield non-nursing things, that may be a GK and geography and mathematics, reasoning, which is there in your RB syllabus. We have included every question, and we are giving the practice to the each and every single question. Okay, so I think you people know the pattern of the RB exam, where it will be coming the 70 nursing and 30 non-nursing. So this 30 non-nursing is the rank deciding one. So we are specially focused and concentrated on this one. And these are in the nursing. You people know we are expert to deliver the content in the nursing. So there is no deficiency. The fully loaded gun machine for to give the sure shot to your RB nursing student exam. If you are interested, so choose this particular 30 topmost test series. So solve it as soon as possible. Know all important questions, all know basic questions which will come in your RB nursing student exam. Okay, so then all are preparing for the mains. Norcet mains exam. Okay, for you people, we are also having the we are having the loaded gun for you people. Okay, so where you will be getting the most important fully loaded 20 fully planned practice papers, that is live. Okay, that is the live. Okay, morning 6 a.m. to the 11 p.m. you are getting the live papers. Okay, so at the 11:30 you will be getting the all India rank already 8 to 9,000 plus subscribers. They are using that one, which are specially focused and built for them. So if you are interested, so you can also join the series and take a benefit of this one. And before joining, read the feedbacks what we have, what our students given, and what our beneficiaries given in the previous prelims exams. Okay, so as a proof of that, the uploaded PDF is also there in our app, so you can look at that one. Okay, so yes, I hope it's clear to everyone, and we will meet in the tomorrow's class. So that is going to be a most important class again to you people, where I am coming with again core important, very important concept. So the classes will run till your RRB exam until your main Norcet exam. So there is no any stoppage in the classes. And the non-nursing portions, the Sunil sir also he is covering. And Sunil sir promised us he will give all the very important core concept for your RRB exams for the non-nursing portion. So don't have to worry about that one. But your effort should be 1,000%. So when your effort 1,000%, our effort 2,000% means yes, the result nowhere it goes, it will definitely comes to you. Okay, so we'll meet again in the next class. Tab tak ke liye, Jai Hind, Jai Bharat. To download to use this test series, the link is there in the description box. You can join there, and if you want have any doubts related to any subject, if you want to discuss with other aspirants, miss the link is there in the description box to join our WhatsApp groups. You can join from there and clear your doubts. Okay, so tab tak ke liye, Jai Hind, Jai Bharat. We'll meet in the tomorrow's class.